and welcome everybody to a session on QRISK3. And as Keely's just said, my name's Michaela and I'm a cardiovascular nurse, and I've recently joined the team here at Public Health England. I'm hoping that you can all hear me and that you can see the screen. We've got Hannah and Keely here who are checking on me, so I'm just going to go into it. I thought it would be useful before we start to be able to think about what this webinar is going to be about. This has been quite a hot potato for a little while now, QRISK3. And so what we are going to cover is the challenges of updating any algorithm that's used within software, what those changes are that's going to happen, what are the implications for the programme and for our patients. What I'm not going to cover in this webinar is about what is absolute risk, what is communication of risk, how does that get communicated to patients. That's a whole different thing and far beyond the scope and the timing of what we've got this afternoon. So apologies if that's what you were hoping for, but hopefully we will be able to cover that at another time. But I really wanted to get to grips with the practical issues around this change in the algorithm. This afternoon, I'm not going to be giving you all of the answers to possibly all of the questions that you might have. It's been quite a long journey that we've been on trying to get an agreement with QRISK3 and how it's going to be worked. So I'm hoping to give you an update of where we've got to so far. But when we get to the discussion session, we'll be able to really dig down on where do we go next and how do we make this better. So what is the challenge? Well, the challenge is the annual update that happens with QRISK. QRISK itself is an algorithm, it's a computer program, and it is based upon the general population that we have in England, in more so that in practices that have to start off with a part of the QRISK database, and that's 1,243 practices. Now our population changes over time, so for example our obesity rates is rising, yet our smoking rates are falling. This means that in the computer algorithm, in the QRISK algorithm, that makes a difference to how the formula works. Alongside this, we have improvements in data quality. So recording of ethnicity data, for example, has really improved over the years. And so we have more, because there's more complete data that's sitting out there, the actual indications that has upon somebody's their ethnicity has on their risk score. Sorry, I was struggling then for a second. I was trying to make it sound really clever instead of just talking like I would normally talk and just do it this way. So because that's got better, we've become more robust, or QRISK has become more robust. So the QRISK algorithm is remodeled every year, apparently, or as we know, and they update it all the time. So when QRISK2 came in, that had some extra changes on, and certainly the last year's update, or 2017 update, did include some extra fields, such as atrial fibrillation. Now, that wasn't really a problem when it came to our programme, because we exclude patients with AF from an NHS health check. So our first hurdle was actually getting an agreement. We knew a decision had to be made. We couldn't stand still. Something had to happen. And so that was getting an agreement between Public Health England, QRISK, they're the people that make the QRISK algorithm and software, and the MHRA. That's the organising body that we have.
So can I just check, can everyone see the screen? Because I've received a few messages saying that people can't see the screen. Okay, sorry, I've just realised, people who've dialed in, you won't be able to see the screen, but the presentation will be on the NHS Health Check website after it has been presented. Sorry.
Yeah, that's okay, that's okay. And actually, what I can tell you is there's not a lot of information on the screen, and at the moment you've just got a picture of a man jumping over a hurdle. So for those on the phones, just visualise that and you'll be okay. So the changes, what have the changes actually happened in QRISK3? Well, we know for the data that we require as part of the health check programme is that a patient should have their 10-year risk of developing cardiovascular disease should be calculated using QRISK. Now, we know that QRISK has been replaced from QRISK2 to QRISK3, and it includes 7 further fields of data. These are chronic kidney disease, blood pressure variability, migraine, steroids, lupus, atypical antipsychotics, severe mental illness and erectile dysfunction. We know any patient with a diagnosis of these is at a greater risk of developing cardiovascular disease, and that's why it's being included in at this moment. So what we hope, or what we know, is the addition of these variables will actually allow a more precise identification of those people who are most at risk of heart diseases and strokes. What does that mean for general practice? Well, the agreement that we've had, and this is the agreement that's taken quite some time between ClinRisk, PHE and MHRA, is that if any person has any of those newly included variables already coded in their GP system, then this information should be automatically pulled through into the QRISK calculator. That means that the people delivering the health check do not have to ask any of these extra questions, but they will have to act upon the QRISK score that comes through. If the patient doesn't have any of those variables coded, then their QRISK will remain as it would have done with QRISK3. But if they do have any of those, their QRISK will be higher. And actually that means there is a potential knowledge and training gap in the communication of risk that will need to be considered. I often get asked what's the difference between QRISK2 and QRISK3. Well, QRISK2 as an algorithm has not been updated for 2 years. QRISK3 has been refreshed, and I'll show you a little later the difference that makes to a patient's risk, and it just refines it a little bit more. What about if the health checks are happening outside of general practice, or they have a third-party set of software? We don't expect that the extra fields as part of QRISK3 to be asked as a health check. What we need for as a part of a health check is just the mandatory fields that have already been agreed. So those extra 7 variables, if outside of general practice on third-party software, then the provider does not need to ask those questions. However, the score calculated in this way will be known as a limited QRISK3 score. And that means that actually if a patient does have any of these other conditions, that when that information goes back to general practice, the patient may well benefit from a full QRISK score calculated. And that's assuming that those fields are already sitting there on the practice system. Now, this approach, as I've already said, has been agreed. This was the best fit we could get, and this guidance is being kept under review by SCAP. It has already been to SCAP, who have agreed it and signed it off, and that's how come it's made its way into best practice guidance. But yeah, this is the best agreement we could get between all 3. So that was the first hurdle we got over, and yet getting the agreement was literally the first hurdle. What we have now are so many more hurdles ahead. And as many of you know, I've been a part of the programme before PHE in a variety of guises, and I'd like to think that I've understand the challenges that are ahead, and I hope that we at PHE can help support the programme in embracing and working through the challenges that we'll have a variety of questions here. Submit questions in the survey that Keely sent out. I've just taken a flavour of them here, and I think it's more to consider the answers rather than me having the definitive answers at this point in time. It was getting over the first hurdle that was our first challenge. So the first question, and then one of the and I think this one varies on depending on which system it is. It also, we're compromised by the extra switchover trying to approach the other systems and find out what they're going to be doing about it. And I have had a note from QRISK asking, can they share the agreed comments that the agreed statements that we have? And of course, we'll happily allow that sharing anywhere. What about those places that have developed their own templates? Well, a lot of some places have got brilliant templates and have spent a lot of time doing them. And if at all possible, we would advocate that you include QRISK3 as the algorithm to pull in a slightly more updated version. But again, I don't think there's a need to rush towards this. I would recommend you do it at the time when you would naturally be updating the templates, because there's probably other bits and bobs, and it's all to do with, you know, when your contracts are going out and things like that. So it's come out in best practice guidance, but don't rush. And when we see shortly what are the implications going to be for this change of QRISK, I hope to make you feel a little bit more comfortable that for the majority of patients, it won't make that much of a difference. The alternative providers, they often use independent software, and I've already been asked, what will the cost be for that one? So that wraps together question 3 and question 4. And at the moment, we don't know what the cost will be. We know that alternative providers, when they have purchased the algorithm before, have had to pay a fee. I guess it's whatever they would normally pay every time the algorithm gets upgraded, but that's certainly something we can speak to QRISK about, but I'm not entirely sure we can negotiate ourselves, but I'm sure it's up there for negotiation. One of the biggest implications and for the programme is actually thinking about the training, because people meaning the people delivering health checks, will need to understand that this QRISK will be altered. It could be slightly different for some patients, and they are going to have to communicate QRISK, which is already very difficult to communicate anyway, without necessarily knowing why the QRISK may have been altered. And I think that's definitely something to be pursued in the forthcoming months. What it means for patients, and these are the people who are at the end of the health check. These are the people, and I say the end because it's, to me, it's a big triangle, and at the bottom of the base is masses and masses of patients who are having their health checks done. And will it really make a difference to a patient's calculation? And how might it therefore change a patient's pathway? Now, as I've said, this session isn't about actually teaching people how to use QRISK or explaining what the algorithm is or explaining what absolute risk or how to communicate risk. But what I thought would be useful is I've gone on the online version and taken some screenshots, and we'll walk you through what you can see the subtle changes are in the difference between QRISK2 and QRISK3. So this is a screenshot of QRISK2, and this is a 64-year-old man who is white. I've left the postcode blank. I've kept it as a very bland clinical information, and this is just simply the fields that show up whenever you click onto QRISK. He doesn't smoke, he doesn't have any diabetes, he certainly doesn't have any family history. His cholesterol is 4.5, his ratio, and his blood pressure is 120, his height is 175, and his weight is 80, which gives him a BMI of 26. And this chap's 10-year risk is 12.9%. That's using QRISK2. Now, QRISK2, as I've said, is the algorithm that hasn't been refreshed for a couple of months. So what happens if we actually take the same variables and put them into QRISK3? Well, it changes from 12.9 to 11.6. You can see a slight change in the diagram here, but in essence, his risk has changed a little bit, but will that make a difference to what we do in clinical practice? And the answer for this man is no, it doesn't. He will still remain on that 10 to 20%, which will be, you know, some lifestyle advice or lots of lifestyle advice and offered a statin. And of course, if he chooses not to take the statin, he'll go back to a 5-year call and recall. And if he does, then he will go for an annual recall. So for this person, using QRISK3 hasn't made a difference to the clinical pathway. This person, let's go back to QRISK3, so back to the 11.6, and now let's see what happens if we add in migraines. So this is one of the new variables, and you can see on the left that I've down here, I've ticked that this chap's got migraines, and it's changed his risk to 12.8. So again, this hasn't changed his pathway. If this was a patient who was sitting in general practice, this won't make a difference to what somebody does with him. And again, if it's a patient that was sitting out in a pharmacy or in a community program, this wouldn't make a difference in the pathway. But instead of migraines, what happens if he had lupus? Now, of course, lupus is not necessarily the most common condition of a man aged 64, but I just wanted you to see what, again, that does. Now, lupus is one of the things that will significantly increase your cardiovascular risk when it comes to QRISK. And so it's now pushed this chap's QRISK up to 17.4. That means clinically we do the same thing. He stays within the same treatment pathway. But is lupus that common? I want us to try and think about the number of patients this might affect. Well, lupus is, in terms of prevalence, is relatively small. It affects somewhere between about 0.2 or up to about 1.5% per 100 patients. And they are predominantly female, and actually a lot of them will be under the age of 40, so won't be part of NHS Health Check programme. So whilst this is really significant when it's there, it won't affect too many patients in our programme. Now, had, for example, this man been a smoker, then this may have changed him into the next treatment threshold. QRISK works differently with different ethnicities. So this is QRISK3. Now, I'm not going to walk you through what ethnicity does to QRISK because I'm making the assumption that you really all ought to know that. But just to show you here that if we change the man to being Black African, we put his QRISK at 7.9. And this is using the same, you can't really see it, but the same bland profile that he doesn't smoke and he doesn't have any of the other things. His cholesterol ratio is 4.5. So what happens if we use this same man and we give him erectile dysfunction? Oh, that sounds awful, doesn't it? But you know what I mean. We're not going to give him erectile dysfunction. But this changes his risk from 7.9 to 9%. Again, that stays in the treatment threshold that is come back in 5 years in terms of QRISK. Now, when we come to the prevalence of erectile dysfunction, that is much higher than something, say, lupus. So based on the Massachusetts male aging study, just over half of the population of men aged 40 to 74 probably have erectile dysfunction. Now, whether that's all been accurately diagnosed and coded is another matter in terms of recording in a patient's notes. But what this does mean is that there's a potential for this to have erectile dysfunction to have a bigger impact across the programme, just simply because there are more men with it than what there are people with lupus. What about how can it change thresholds? Because this is the bit that gets really challenging, is when the QRISK3 makes a difference to what you would do with a patient. So here now we've got a 61-year-old man who's Indian in an average postcode. He's a light smoker, doesn't have any of these conditions down here. And again, the same bland cholesterol and blood pressure. And I've kept them bland so we can see the changes based on other variables. And at the moment, this chap's QRISK is 17.3%. So that means in the pathway, we would be offering him a statin, all the usual lifestyle advice that's available, offering him a statin. If he says yes, he would go on the regular recall program of reviewing him every year. And if he said no, then we'd be putting him in the 5-year call and recall. But let's imagine this guy's got erectile dysfunction. Then it changes by the simple ticking of here, it changes him to 20.1%. That means the pathway needs to change. That actually, if you look down here, doubles this chap's risk. It was already increased anyway because of his smoking, but it doubles his risk. And therefore, his treatment pathway now has changed from offered a statin to definitely offered a statin and not offered another health check, and they should be seen every year. So the changing pathways is more difficult when it's on the cusp. At the moment, we don't really know the finer numbers of how many people this is going to affect. We've got some good estimates, but the QRISK algorithm has always been changing. Every year it's been changing. I just don't think we've fully realize those implications, and it's just because of these extra variables that have come in that are making it much more complex for us. So what about NICE guidelines? Well, currently the NICE guidance recommends using QRISK2, but and also within NICE, it says we can actually use the QRISK algorithm up to 84 years old. Now, of course, that's beyond the age at which we do NHS health checks. However, a surveillance review of NICE guidance last year, in January last year, actually decided or concluded that a partial review of the guidance is warranted to provide advice on the use of QRISK3. So we will certainly keep an eye out for that one. That's it for whereas we've got to so far, and that's not me and MHRA and ClinRisk fighting over trying to get agreement, but we did have quite a lot of discussions going on. But what I'd really like to do now is open this up for discussion, and I'm just going to, or Keely's leaning over me and is going to unmute everybody for me, and we can then get you to unmute yourselves if you'd like to ask a question, or what you can do is I'll